Okay.
All right, hello everybody. Welcome to today's Fresh Dental Shadowing session. Today we have Dr. Choi with us, who is going to be teaching us about her journey in dentistry and giving us advice and looking at different cases. So you can take it away.
Great, thank you so much. I'm happy to be here to go over everything with you guys. And if you have any questions, feel free to ask at the end as well. So my name is Dr. Amanda. I'm a pediatric dentist and I am board certified. So I'll be going over a little bit about my journey to get here, what I'm doing now, and then also I'll be going into pediatric dentistry specifics too. So first I'm going to start by going over my journey. So this includes my education path as well as some dental mission trips that I went on. And then I'll be getting into the portion about pediatric dentistry. So I'm going to be going over some terms and things like that that you might find useful to you. It's also great if you want to reference it back later too. The great thing, there's also a lot of new technology that's available in pediatric dentistry, including some that I just learned about at our pediatric dental conference a few weekends ago. So I'm going to be sharing that with you all. So it's pretty new information. And then I'm going to be going over some specifics with clinical pediatric dentistry, so chief complaints, terms that we use, and a few case presentations as well. And then I do have some tips for all of you. These are just my disclosures. So consent was given by all of my patients. You'll see on my Instagram, I am an ambassador for a few different companies, and this presentation is for educational purposes. So starting with my education, I am what we call a 3+3, which means I was in the accelerated dental program at University of the Pacific. So I applied in high school and I was accepted actually into the 2+3 program. I ended up choosing 3+3 so that I could study abroad, which I'll get into a little bit as well. So in 3 years of undergraduate education at UOP, I was able to get my Bachelor of Science in Biology. And I was also a Powell Scholar, which also enabled me to have the opportunity to study abroad while I was there. Then I went on to the Degoni School of Dentistry, which is in San Francisco. So I believe it's still the only 3-year dental school. Correct me if anyone knows otherwise, but I do know there are some other accelerated dental programs available now, but I believe Degoni is the only 3-year dental school. And then for residency, I did a 2-year program at Cincinnati Children's Hospital. So I did leave California for a few years. I braved the snow. And then I came back to the Bay Area, which is where I've been practicing ever since. I am an associate in a pediatric private dental practice. And I received my board certification, and I'm teaching at Degoni School of Dentistry at the pediatrics clinic as well. So a little bit about the dental mission trips that I went on. I actually was fortunate enough to do 2 during my time in dental school. I highly recommend that you consider this when you get into your program of they have this as an option. So I went to both Jamaica and Fiji, and part of the reason I was able to go on both of these so the study was basically to determine the oral health outcome of a sugar increase in the diet for children internationally. Our dental school also sent some students to the Philippines, so I had some students bring this information there as well. So I was able to compare the children's caries rates in all 3 areas. And that way we could find a correlation between the sugar based on their diet in different areas, so that we could better tailor our oral hygiene recommendations when we went back on these mission trips. Because coming to the root cause of things is we want to figure out why they're getting cavities. If we're only there for a week, we can only fix so many teeth during that time. But if we can start to educate them to reduce their caries to begin with, we have a much better chance of making a bigger impact. So that was one of my projects. And then a second project that I did was about elementary school oral health education. So I worked with a few other dental students. If someone did like preschool children, someone did a high school program, and I focused on the elementary school level education program that we developed. Okay, so let's get into pediatric dentistry. It is an age-defined specialty, so that's the main thing about why it's pediatrics, right? And we do provide both primary and comprehensive preventive and therapeutic oral health care. So we're not just treating the problems, we're also trying to prevent them and educate along the way. So we do see infants. I've even seen babies who are just a few days old who are born with natal teeth. And I've seen all the way through adolescence, even some sneak in going through college. They want to stay at their pediatric dentist. But starting around 12 is when you have all of your adult teeth. So depending on your needs, sometimes we graduate you around 12 years old, sometimes 18. It just kind of depends on what your dental needs are. And during our 2-year specialty program, we do receive extra training in several areas. So a main one is child development. We also learn how to take care of patients with special healthcare needs. We learn specific behavior management tools. We go in depth into 3 different levels of sedation. So oral sedation, IV sedation, and general anesthesia. And then we also get a little bit of orthodontic training as well. Okay, so the practice that I'm at now is a private practice in the Bay Area. We do have 4 different locations, and I work mostly at 2 of them. So we are a pretty big private practice. We also have an orthodontist at a 5th location that we work with for all of our patients. So it's really nice that we have an orthodontist within our practice as well. If I manage to get a day off, I do try to go up to the dental school to teach at the pediatrics clinic. It's really fun staying involved with the dental school and giving back where I went to dental school. And then there's a few deciding factors, I would say, when you're considering what kind of practice you want to join. So the quality of care, which location you want to be in. So for me, that was really big since my family's in the Bay Area. And then you want to talk to the staff, make sure the staff is happy at the practice that you're thinking about joining. And also, I would say there's a big difference, even just within the 2 practices that I work at, between the different types of patients and parents that we have. So depending on your skill set or your preference of what type of patients you like to work with, that can definitely impact your decision as well. And then I would also take a look at what their schedule is. Some practices you'll see 10 patients a day. Today I saw 47 patients, so it can completely vary depending on what type of practice that you're joining. So I did come up with kind of a sample schedule so you guys can kind of see what a typical day looks like for me. I typically work 4 days a week, and sometimes I'll do a Saturday. This week I worked 5 days, so it just kind of varies. But I definitely work Monday through Thursday, and I do 2 days at each of those locations. Within our group practice, it's nice that we have a few different pediatricians, so we're on call a month at a time. It's different than in residency, where every time I was on call, I had to pretty much go into the emergency room because we were a hospital-based program. In private practice, for us, we get some calls, but it's not very often that we have to go in person. So being on call for a month isn't as bad as it sounds. And then I do a general anesthesia day once a month. So this means that we have a medical anesthesiologist who specifically works with children, and he will come into our office specifically. So there's a lot of screening process to determine which patients are qualified to safely do this procedure. And he will put the patient to sleep, and then we will do all of their dental treatment in usually about a 2-hour time slot. Every morning we start our day with a huddle. So we kind of want to go over what we're expecting, if there's any medical alerts, any maybe emergencies that we're expecting, or where can we squeeze in an emergency if somebody calls. And then I always like to review my patients at least the day before. I usually look a week ahead of time just to make sure the schedule is laid out appropriately. So breaking it down a little bit more, you can see this is a sample of a 4-column day for me. So the first column would be my treatment column. So for us, it's nice. We do have our treatments in a quiet room. So this means that they're away from the patients who are getting cleanings, just in case they're a little bit more nervous. And we do have our nitrous oxide or laughing gas set up in these rooms as well. And we do schedule about an hour for each of these treatment appointments because I am popping in and out sometimes to go do these hygiene checks. The other 3 columns are broken up mostly for recall appointments, but we do always find time to add in new patients. And our new patient appointments, we do make those longer because we want to make sure we have ample time to review everything with the parents and the patients as well. SDF is silver diamine fluoride, which I'm going to get in a little bit later as well. We could have an office visit, which could be an emergency, or if they're having pain, something like that, which I'll get into with the chief complaints as well. Okay, let's see if my video will work. This is a little tour of one of our practices. This is my boss right here. Okay, so this is one of our front desks, and we do have a big and little door, which is a big hit with our patients. Go through the little door. We do have a consult room. We do have several quiet rooms in each practice, so this is where we would do our treatment. And then this is our open bay setup. So we do have benches, and this is where we do our cleaning appointments as well. If there are patients that request, or they're maybe nervous, or certain situations, we can also do cleanings within the quiet rooms as well. Okay, getting into new technology. I don't know if this is considered new anymore, but I do think it's a really exciting thing that's nice that it's available for pediatrics specifically. So we have the dry shield system in our practice. There's also, I think it's called the IsoLight system, which has a little light actually within the isolation system. But basically it connects to the suction, so it acts as a suction appliance. It also has a bite block, so it helps keep the mouth open while we're doing procedures. It's a really great tongue shield, and it'll protect the oral pathway. So basically we want to make sure our patients aren't swallowing anything. So this is also really awesome because we can do 2 quadrants at one time. So for kids, a lot of times speed is very important if we don't know how long they're going to be able to sit still, or how much they'll be able to tolerate. So having the ability to isolate 2 quadrants at one time is really amazing. Okay, as I mentioned, silver diamine fluoride. So this was kind of becoming popular towards the end of my residency. I think it's a lot more common now. So silver diamine fluoride, typically it's a 38% solution, and it's a topical antibacterial and remineralizing liquid that we use to arrest cavitated lesions in primary or permanent teeth even as well. So let me break that down a little bit more. Basically what we're doing is the fluoride is going to help with any sensitivity within the tooth. And the silver actually, it almost forms a little barrier over the cavitation where the cavity is, and it's going to help reduce the chance of that cavity from growing bigger. It does require a minimum of at least 2 applications, but the really great thing is that it's a very quick procedure. And so it's good for tinier patients, or if there's just the start of a cavity and we think, okay, maybe in 6 months to a year, if we do need a filling or some sort of restoration, it'll be a little bit of an easier procedure for you. So I always like to emphasize to parents, this is not a cure, it's not a magic wand, but it is a treatment option that we have available. Originally, this was used for tooth sensitivity, so you can also use it for that, especially like if a root is exposed, like in this photo, you can use it for that as well. But this is really great if the parents don't want to take their child to the general anesthesia route, but they're only 2 years old and they're not having too much pain. We can apply the silver diamine fluoride. A contraindication that we cannot use the silver diamine fluoride is if the cavity is already into the pulp. It's no longer a good option. So it's all about case selection, but this has definitely opened up a lot of new doors and given us a way to kind of buy some time until our patients are a little bit more cooperative and just able to do treatment safely and comfortably. Okay, zirconia crowns. So these are amazing because they're much more aesthetic for our patients. I would say the one downside is they're not as conservative or as durable. So a lot of patients, especially children, do grind their teeth, and so it doesn't necessarily hold up as well as a stainless steel crown. And you're also removing more tooth structure in order to put these crowns on. They're not flexible, so the stainless steel is a lot more malleable, so we can get it to fit a lot more easily. Until now, this is the new thing we just learned about a few weeks ago. They do have a white crown that's coming out for children called BioFlex. It's not released yet because they're still doing studies, but I got to touch it and I got to see it. It is real, and it's actually basically a zirconia crown, but you can like bend it and move it a little bit. And so it's pretty fascinating. They've done over 150 of these crowns so far, and only 4 of them, it was 4 or 5 of them have come off, and 3 of them was because the child was eating candy they weren't supposed to be eating. So we'll have to see when it comes out, but the preparation is also of the tooth is more similar to that of a stainless steel crown preparation. So that's also really exciting if it's going to be more conservative for the child as well. So hopefully they're thinking maybe later this year or early next year, we will have that as an option for our patients as well. Okay, and then Hall crowns, this became a lot more popular during the pandemic. Basically what it is you're still using the same stainless steel crown. However, you are not numbing the patient, you are not prepping the tooth, you are not removing the cavity. And so again, case selection is very important here, but basically you put a little separator, a little rubber band if there's a contact between the teeth. This could be just for 10 to 15 minutes. Sometimes you have to leave it for a day or two. Then you're bringing back the patient, removing that little rubber band, and then you're finding the right size crown to glue it onto the tooth. And so the way that this works is you're basically sealing the bacteria, so it's not having access to the food or anything inside of the mouth to continue to spread and grow. And by sealing it, you're preventing any sensitivity for that tooth as well. So even if you only do this for a year or 2, if you end up having to do a pulpotomy, at least the child may be 4 years old instead of 2 years old. And the best thing during COVID was that you can do this whole procedure without any aerosols. So I think that's why this became a lot more common in the past few years. And it's a really great option, again, if our patients or our parents don't want the children to go to general anesthesia. So another really great option that we have. There we go. Okay, so some common chief complaints that I get in my practice. So pain is probably one of the biggest ones. So lots of things that we have to rule out when we're trying to figure out the source of pain. So usually the main thing is we want to figure out where the pain is coming from. Sometimes the child can tell you, and sometimes they can't. This could be if they are nonverbal or they're too little. You kind of just have to look and see what's going on. So a common reason would be cavities. Could be an infection, there could be swelling for some reason, if there was trauma, it could just be from new teeth coming in, there could be a canker sore. So there's lots of different reasons that you want to run through and kind of see what's going on. Like I mentioned, loose teeth are a common complaint. Especially, I did find a little photo for you of what we call ectopic teeth, or shark teeth, as parents call them. So a lot of times we'll see shark teeth where the child has a really small jaw. They don't have enough room for their new teeth to come in, so they find their way in behind the baby teeth. A lot of times these baby teeth still will fall out on their own. They just can take a little bit longer because the root is not disappearing as quickly as we need it to. But sometimes we do have to help take out these baby teeth. So it's always a good idea for us to at least do an assessment and see which side they're on in that case. And then, as I mentioned, dental trauma is something that we do see. So an avulsion is when a tooth gets completely knocked out. And so if it's a baby tooth, we're just going to leave that tooth out. If it's an adult tooth, it is time sensitive and we want to get that tooth replaced within an hour, ideally, for the best prognosis. There could be a fracture of the tooth. A subluxation is where it's bumped but not really moved out of place. And a luxation is where a tooth gets bumped and it is moved. So sometimes that can impact the child's bite. It could prevent them from eating. So we would have to come up with a treatment plan for that, depending on how it looks. Okay, so let's get into some specific terms for pediatrics. The main difference, I would say, is that our baby teeth, they are numbered with letters, okay? And our adult teeth are numbered with numbers. So a lot of time our patients will ask us, but A is not a number. So sometimes we have to explain that to our patients when they hear us calling out teeth. But you always want to start in the upper right and work your way to the upper left. And then you're going to jump down to the lower left and go over to the lower right. So again, with baby teeth, you would start with A, go over to J, and then on the bottom, you go from K to T, versus with the adult teeth, you would go from 1 to 16, jump down and go from 17 to 32. Looking specifically at the tooth surfaces, there's a few different names that are important to know when you're referencing the teeth. So the labial, that would be the lip side of the tooth, so the front part of the tooth that's facing your lip. For your posterior or your back teeth, that labial side, we also call it the buccal, because the buccal, that's your cheek area, so it's facing your cheek. You can also call it the facial, so it's facing the front of your face, is how you can remember that. And then the opposite, the inside of your tooth structure, so on your bottom teeth, you'll call that lingual because it's facing your tongue area. And on the top, the inside of your teeth are called the palatal side. And then in between your teeth, so the areas that you're flossing, if it's facing the midline, it's called the mesial. And if it's facing the back of your mouth, that's called the distal surface. So that's a common area that we will see cavities. So we'll say there's cavity on the mesial of 3, for example. And then just to look specifically at the tooth anatomy, so most of you probably know this, but the top part of your tooth that usually is showing in the mouth is called the crown. And then the area underneath the gums in your bone are the roots of the teeth. And then the outer layer of your crown is called the enamel. And then the second layer is called the dentin. And then inside of that is the pulp. So think your nerve, your blood vessels, everything is in the pulp tissue. So it has a special term in teeth. Okay, so Frankel, this is a behavior rating scale that we use for our patients in pediatric dentistry. And this is really important for treatment planning and even for scheduling, because a lot of patients, if they have poor behavior, you usually want to schedule them in the morning when they're well rested. They tend to do a lot better than after the school. So we kind of come up with this Frankel scale each appointment to see how they did during the appointment. So a 4, that's the best child. They love coming to the dentist. They've been talking about it for weeks. They lay down, they open their mouth, they follow directions. They're so excited. They're asking questions. They're laughing. They leave with a smile on their face. That's great. We love those 4 patients. We also get training though on the 1, 2s, and 3s. So a 1 is where they are crying. We call it loud singing in our practice. They're fearful. They actually have dental anxiety. They can even be oppositional. They may not want to do anything. They may not even let you look in your mouth. And then there's the 2s, 3s that are kind of in between that. So 3 is usually, they're still really happy. They may just not let you do everything. And then the line between a 2 and 3, it just kind of depends on how many things go well versus don't go well during an appointment. So every dentist probably has a little variation within the scale, but it's a good idea. Especially at our practice, we have different dentists, so that way we can look at the last note and see what worked well for a patient and what didn't. Okay, this is probably one of my favorite things about pediatric dentistry, is the kid-friendly language that we get to use, or dental euphemisms. And so I threw up a few here. Again, you can make your own, and it kind of changes based on the patient, but it's really fun to use these because you want to make it seem more exciting and understandable to the child. Are they going to want to hear that they're bleeding? No. Are you going to have to go over post-op instructions with mom after an extraction that there will still be blood and to be aware of it? And so if you call it red, mom knows what you're talking about, but you're not saying blood in front of the child and scaring them. Also talking about sugar bugs in terms of cavities. Maybe a good or bad thing, I don't know, about COVID is most kids know what germs are now, so kind of relating it into that is an easier way to explain cavities to children. Our nitrous oxide, again, that's a fancy term that a 4-year-old's not going to know, but you can call it silly gas or happy air, laughing gas. So just lots of different names for different things that we use within pediatric dentistry. Okay, so occlusion. So this is how your teeth come together. So this is really important for pediatrics because we're monitoring mouth is growing and changing every single appointment. And it's specifically when you're going from the baby teeth to your adult teeth. We want to make sure that if something is not going appropriately, sometimes we can intervene with the orthodontist to help bring the teeth into a better occlusion. So this is something that's really important to understand. So the primary molars, so the first baby molars, the position of them helps determine the position of the first permanent molars when they come in, and eventually how your permanent molars will come together, which is what determines your occlusal relationship. So I do have a little chart here that's probably the easiest way to understand it. Can you see my pointer? Okay, cool. So the left side here, this is our baby teeth occlusion. And then on the right side here, this is your permanent molar relationship. I would say maybe the mesial step is probably the most common one that I see, but I still see all three of these quite often. So the distal step, this is where your top molar is going to be a lot more forward than your bottom molar. And basically what this turns into is your class 2 malocclusion in the adult teeth. So when you see kids that have an overbite, their top teeth are a lot more forward than they should be. They're at a lot higher risk of fracturing their teeth if anything were to happen. So this is what usually the baby teeth will show up as. And then a flush terminal plane is where the distal or the back surfaces of those baby molars are in a straight line. And you can see it kind of goes into all the different permanent teeth occlusions. And then a mesial step is where the bottom molar for the baby teeth is more forward, more anterior than your top baby molar. So if it's pretty significant, this is where you'll see an underbite. So think of like a dog that has an underbite. It's really cute, but eventually they're going to need braces, possibly even orthodontic surgery. Most commonly, hopefully we'll see a class 1 occlusion though, which is what we are aiming for. So again, this is good that I see this quite often. Okay. So this is another little picture showing the baby molar relationship, and it's including both baby molars and the canine. So again, the distal step, that's where you may see the class 2 or the overbite. Flush, commonly we'll see that either turn into a class 1 or a class 2 with the overbite. And then the mesial step hopefully becomes a class 1, and then the exaggerated mesial step, a lot of times we'll see that underbite or the class 3. Okay, time to get into case presentations. Are we doing okay on time? Okay. Okay, so for my first case today, I had a 9-year-old healthy male patient who came in for treatment. He had what we call a recurrent cavity, or this was the second time that he had a cavity on this baby tooth. Really healthy. Most important thing that you review the medical history, I was going to say health history, before starting anything. So he doesn't have any allergies, not taking any medications. So a nice healthy boy. So the treatment plan we came up with the parent and the child is we're going to use laughing gas with the nitrous oxide, and we are going to do a filling on that tooth. So again, if you remember, so this is upper left, this is the back baby molar. So this would be tooth J. And then we're doing a filling on the mesial occlusal. So the mesial, so the front part of the tooth facing the midline, and the occlusal is the chewing surface of the tooth. I don't know if I went over that. So the mesial occlusal, you almost always have to include the occlusal when you're doing the interproximal, because you have to come through the top of the tooth in order to access that interproximal surface, or where the mesial distal cavity is. In composite, that's the white filling material that we will be using. So these are some photos that we took of his mouth inside, and then I did flip it. This is a mirror angle, but so you can see he is mixed dentition, meaning he does have some of his adult teeth, baby teeth, and then those adult first molars back there. It looks like he has some nice sealants on there as well. Okay, so this is during treatment. So you can see we did use the laughing gas. Okay, so we went to about 40%. And we did start with our local anesthesia once he was settled on the laughing gas. So we do use a topical anesthetic, which is a little numbing jelly first. Great for all patients. It shouldn't just be pediatric patients. It's sort of pre-numbing the area and making the local anesthetic process a lot easier. I also love to shake the cheek to kind of distract, but it also helps with the administration of the local anesthetic agent. Really important for children, we also weigh all of our patients before we start treatment so that we can do their dose of how much they can receive based on what they actually weigh. And you can also see that we're using the dry shield isolation system. I think I have another picture, but you'll see he is wearing headphones. We do have TVs and movies that the children watch during treatment, which distraction is a great behavior management tool for children, also adults, you know. And then we do provide some sort of glasses, either sunglasses if the light is too bright for them, or clear glasses. I prefer clear glasses so I can see if the child's falling asleep or how awake they are, but he was a really good patient, so. Okay, so going into a little bit more specific for our filling material and the process. So this is great. This is from dental school. We were learning pediatric dentistry, but this is the anatomy of what tooth J tends to look like. So the meso you can see is on this side. So this is the preparation. So we would come in this area, and then this is flipped, but basically we did have to come in and you do a little retention area on this side, and then we call this dropping a box, which you'll learn in dental school. And so this is how we get all the way down to the gum tissue, make sure we're removing all of the cavity. It also helps with retention or holding the composite, the filling material in place. We like to use these de novo matrix bands, so they're already attached in rings, so they come in different sizes based on the size of the tooth. And we do place that around the tooth when we're placing our filling material, along with a wedge, to ensure that we're not gluing the teeth together when we're putting the filling material in place. Oh, there we go. I was like, we skipped one. Okay. So post-operatively, he did amazing. We were able to get the entire filling done. Oh, sorry. We were able to get the entire filling done, and he did amazing. He just relaxed and watched his movie the entire time. So I would consider him a Frankel 4 on that behavior rating scale. And then I did go over post-operative instructions with the parent. So he is going to be numb for about 2 to 3 hours afterwards. So we want to make sure that they're not biting their lip or cheek. So I do recommend that the parent closely watch them during this time. But by placing the gauze in there, it also will help reduce the chance that the patient is biting themselves without knowing it. They often don't need it for filling, but over-the-counter children's Tylenol if they're having any soreness. And then I do like to go over sometimes the bite or the occlusion can feel different if we're fixing cavities. So I tell them to give it a day or two, but if they need any adjustments, any further adjustments, to come back in so we can adjust it further. We always do our check of the bite before the patient leaves, but the child is numb first, so it's hard for them to know during the appointment. Also with children, it's kind of hard to know at first, so that's why it's a good idea for the parents to give it a few days. And then we tell them they can get right back to normal brushing and flossing that same day, and we do give contact information, so if they have any questions, they can always reach out to us as well. Okay, so for my second case, I'm going to be going over for an 8-year-old male patient that was referred from another dentist because this patient had an abscess or an infection in the lower left quadrant. Again, this is a healthy patient, which was great, so not taking any medications, no allergies or anything like that. So our treatment plan was to use nitrous oxide, which I do typically tend to recommend for extractions for patients. For children, sometimes they really don't like the pressure even once they're numb. It's hard to explain the difference for children. So the nitrous oxide will really help them relax a lot more while we're doing the treatment. Another thing to consider, I think I have some more information in here for you, is about space maintainers when we have to take out a baby tooth early, because we don't want to lose the space for that adult tooth that hasn't come in yet. the teeth are moving and changing, the child's growing, so we don't want to risk these teeth moving together and closing that space. So our treatment plan, based on the amount of teeth that this patient has, is we were going to remove this infected tooth, and then we'll actually be taking an impression for a specific type of space maintainer, because he does have, again, mixed dentition. He has some adult teeth in the back molars and these incisors, and he still has some baby teeth in this arch as well. So this x-ray shows us where the infection is. Okay, so we can see this dark area here. Again, it should look like a root like it has on the distal here, but you can see we probably had a little bit of what we call internal resorption. So basically from the inside out, we're seeing that bacteria affect that too. And clinically, you can actually see, hopefully you can all see, there's a little bubble. It looks like a pimple almost on the gum, so that's an abscess as well. So clinically, we were able to see it, and then we were able to confirm with the x-ray as well. Okay, and this, because it's a mirrored photo, so it is the lower left, but it's flipped because of the mirror here. Okay, and so this, I just circled it so you can see where the abscess is in all three areas. Oh, I corrected this one for you guys. Alrighty. So let's get into the actual case. So again, we decided we were going to use nitrous oxide. So we had that all set. And then once we had the nitrous oxide established, we did give the topical anesthetic and then the local anesthetic. You can also do the band fitting of the molars sometimes before you do the extraction. This patient was pretty good, so we were able to do the extraction first, and then we fit the bands on those back adult teeth. That's the type of space maintainer we were doing. And then we had to take an impression because this has to be made by the lab. Some dentists are amazing and they will make their own space maintainers, but our practice is really busy. We don't have a full lab setup. So when we do need this time, we do send it to the lab. There's a different kind of space maintainer I'll show you that we can do chair side, so in the same appointment as well, which is a really nice option. So this is what the tooth ended up looking like when it came out. So you can see this is where the infection was. We do go over with the parent. There's a possibility that a little root tip may have been left based on how the resorption of the infection occurred. We don't always dig the root tips out for baby teeth because we have to protect the developing adult tooth underneath. And if we damage that adult tooth bud at all, that's not good. So a lot of times that little root tip, it'll disappear just like a normal baby root would as the adult tooth grows in. Sometimes it'll come out. So just something we go over with the parents so they know what to expect, and we check on that at their visits as well. Okay, this is the image that I was waiting to show you guys. So this goes over some different kinds of space maintainers that we do for our pediatric patients. So the kind that I treatment planned was what we call a lower lingual holding arch. Okay, so this can be if you had to take out one tooth, if you had to take out teeth on both sides. That's a really great thing about it, is you just have to have the adult molars in, so they come in around 6 or 7 years old. And you do want to have usually all 4 of those permanent incisors in as well. And so this is just all of these are just passive appliances. We're just holding space so that those teeth don't start to move and close that space. A distal shoe. So this is if we have to take out that very back or the second primary molar, especially if that permanent 6-year-old molar has not grown in yet. It has a little guide plane that actually goes into the gum tissue. So important that you do this the same day as the extraction, since the patient is already numb. And by placing this appliance, it forms a little guide plane that the tooth can just grow in the normal spot it would have if the baby molar was still in place. This is the one I was explaining. You can send this to a lab, but there's actually a way that you can do this chair side as well, which is what we have in our practice. So we fit the band on that back tooth or the front tooth, whichever way we're doing the space maintainer. And then you can custom fit the loop part. So you can cut the wire to the correct space. And so it basically is just a little system that we connect together. We can crimp it, tighten it, and then we just glue it onto the tooth with the little band here. So that's a really great option if you're only taking out one tooth, especially if you don't have that permanent first molar to glue anything onto as well. You missed one. There we go. Okay. So as I mentioned, this patient was awesome, so I would consider him a Frankel 4 as well. Again, harder to take photos on a Frankel 1, so I apologize that they're both Frankel 4 patients, but I did find a photo of what our little model is that we show parents of what an actual lower lingual holding arch will look like. Again, this is a really important part of consent, so they know that it is a silver colored appliance, and the child is going to have that in there until they probably start braces or some other sort of treatment. Post-operative instructions, pretty similar to a filling. You want to make sure that they're not biting themselves, so we give them the gauze, Tylenol as needed, contact information. The main difference, I would say, is I always like to go over it that saliva and blood can mix together. And so this can make it look like the child's bleeding, but it could just be the top layer of that blood clot mixing with the saliva. So I always have parents actually look inside the mouth because they pull out the gauze and there may be a lot of saliva on there that's red, but the child may not actually be bleeding. So I always like to go over that, put a little towel on their pillow that night when they're sleeping as well. And then also diet recommendations. I didn't have room on here, but you want to make sure they're not eating any small crunchy foods that can get stuck in the area before it's really started the healing process. So think like chips or seeds, little tiny things that can get stuck. Also trying to avoid straws, not as big of an issue, not really a risk of dry socket with the baby teeth extractions, but you still want to try to avoid it if possible. I also advise against eating any sort of citric foods, so like oranges, limes, things like that, or spicy foods, which luckily most kids don't eat, but it can kind of burn the area, so it's not very comfortable. And then I really emphasize the importance, especially when I have to send a space maintainer to the lab, that they come back within 2 to 3 weeks for replacement of the space maintainer. If they wait too long, the space maintainer may no longer fit, and then we'd have to start the process all over, or they'll start to lose a lot of space, and that's going to be an issue when the grown-up teeth start erupting. So we really try to emphasize that as well. It has happened. Again, it kind of depends on your patients, what kind of practice you're working with. So it's important to understand that, because if they're not likely to come back, you want to try and do a chairside appliance if possible. Okay, I'm almost done, and then we can get to some questions. So this is just some advice that I've kind of come up with through my journey. Again, the main thing to remember is that everyone has a unique journey. So one thing that's really big to me, especially if you follow me on social media, is that sustainability is really important to me. And I think it'll be really big probably when all of you hopefully are in dental school. It'll be a bigger part of learning how to do dentistry. So just even considering one sustainability practice you can incorporate into dentistry will go a really long way in reducing our carbon footprint in dentistry. So the best one I like to recommend is switching to a bamboo toothbrush instead of a plastic one. Plastic stays in the landfills forever. So bamboo is compostable, so that's a great option you can recommend to your patients or even your friends and family. Taking care of your health is super important. Dental school is a marathon, not a sprint, and you want to make sure you're taking care of yourself. Yes, it can be stressful. Yes, there's a lot of new things that you'll be learning, but it's important that you know how you study best. Getting enough sleep, drinking water, these all seem like basic things, but sometimes they go out the door when you have 10 finals and practicals and patients and all these things happening at the same time. So in college, I really encourage you to find what helps with your mental health and taking care of yourself physically as well. As I kind of mentioned, dentistry is a journey, and the exciting thing is it's always changing, which means you get to learn for a lifetime when you're in dentistry. So CE courses or continuing education is really important. It's a requirement for your license. So it's really great you get to keep learning and seeing what's going on in dentistry so you can provide that better quality care for your patients. Another thing I like to advise patients and anyone going into dentistry is listening. So obviously it's great when our patients listen to us, but also as practitioners, it's important that we're listening to our patients. Okay, so we don't want to just treat the teeth. We want to help the person. We want to help the person that's in our chair, and we want to take a personalized approach. So understanding who they are, where they come from, what kind of risk factors they have, how they grew up, what kind of diet they have, all those different things come into play in more of a functional approach, so that we're not just drilling and filling cavities all day without figuring out why they're getting these cavities. And so that's something you kind of develop when you're in dental school. And then everyone has a unique path to dentistry, so don't compare yourself to anybody else. If you want to be a dentist and that's your passion, you will get there, I promise. So it's really important. All your friends you're studying with right now, these are going to be your peers for life, okay? I have dental friends all over the world, and it's so amazing to be able to come to different people, collaborate with them, go over cases with them. So stay connected with not only your peers but also your mentors, that you form relationships along the way, because that's a really great way to learn and make sure that you're providing that great care for your patients as well. So I think that's the end of my presentation. I'll just leave up my information here if you want to reach out to me at all. And if you guys have any questions, I'm happy to stay and answer some.
Yeah, thank you so much. That was such an informative presentation.
Great.
So we do have some questions for you. So we kind of just want to start like at the beginning of your journey. So just like, how did you decide that you wanted to become a dentist? And also like for pediatrics specifically, like what made you decide to specialize in that?
Yeah, so I would say I've known I wanted to be a dentist since I was 14, but my dad's a cardiologist, my mom is a nurse, so I kind of grew up in a medical-based family. Seeing my dad's lifestyle and how much he was on call and so busy, and he didn't get to see his patients very often. So I knew I wanted to go into a science-based field, but I didn't necessarily like medicine. And so my best friend growing up, her dad has always been my dentist. And so I was around dentistry a lot as well. So in high school, when I started shadowing him and I realized I really did like dentistry, initially I was thinking maybe I wanted to be an orthodontist, but once I got into dental school, so that's another thing, is making sure that you keep an open mind along your journey. Once I got into dental school, I realized there was, first of all, that there's so much more out there in dentistry than I even realized, and I actually wanted to form that relationship with my patients. And so orthodontics is a shorter treatment plan, maybe 4 or 5 years, right? But working with children, I get to see them maybe from when they're a baby all the way up until 18 years old. And so I get to really help them develop those important habits for their oral hygiene during really transformative years. And that was something that really appealed to me because I'm really big on prevention. And so having that opportunity to work with them from a young age was something that was really exciting for me.
Awesome. And then kind of going into like your undergraduate experience, what type of extracurriculars did you do during that period? I know you mentioned you were in like a 3-year program.
I'd have to pull up my CV, it was a while ago. But I remember I was involved in a lot of different clubs on campus. So there was like a biology club, we had a pre-dental club, I was in Give Kids a Smile, so that's where we go out in the community, we do a lot of oral hygiene instruction. I think I was in a few different honors societies, so I was able to do community service through that. I was in a sorority in college as well, so a lot of my pre-dental sorority sisters, we all got to study together, and I had mentors who were within my sorority, which is really great. And so I would just say, don't limit yourself to just dental things, because in college is where you're going to form those relationships with other people that are really going to enrich your experience. And just getting out into the community and getting to do even oral hygiene instruction was so much fun for me, to kind of take a break from school, because it can kind of be all consuming at times. So, I mean, I'm not big into sports. I would go to the gym, but that's about it. But I would just say whatever is fun for you, and you're going to make great friends there. And so, I mean, I think any sort of activity that you have time for and that you're passionate about is a great way to spend that extra time when you're in college too.
Okay, thank you. And then I know you mentioned that you did research too during dental school. So what inspired you to do that research, or how did you get into that?
Yeah. So I did some research in undergrad as well. So I was actually working with little tiny fish. They were really small, and I was helping remove their ear bones actually. And you could study how old they were for conservation efforts, like where to focus the conservation efforts. So that was kind of my first exposure to that kind of research. But then in dental school, at least at Degoni, it was optional when I was there, but now I believe it's a requirement that you have to do some sort of research project. It can be on anything. So it's a really great way to kind of get more information and get to spend more time. And it can be as big or as small of a project, I believe, as you want. I believe there are a few requirements, obviously, but I mean, prevention, oral hygiene instruction, and kind of helping patients change their habits to be more likely to have a lifetime of oral health was really something I was interested in, still am interested in. So I'm doing that research to figure out how we could better help these people that, I mean, we would only go once a year for 5 days to these countries. So we wanted to figure out how to make a bigger impact. And then I was involved in Club Scope and Give Kids a Smile and things like that in dental school as well. So we would kind of just go out and do like oral hygiene on a whim, basically. Like we had all the tools and everything that we were given from the club, but we wanted to do some research and have more of a set program so that new people who were coming in could kind of go out and teach to these schools. So that's why we helped develop those specific programs. So it was just something more like identifying a need and how we can help with that need. And so those were the two projects that I kind of got involved in.
Okay, that's so cool. And then how would you describe that transition from undergrad to dental school?
Yeah. Okay, so Degoni is a little different because we start seeing patients our second year. So you're kind of, well, you're very busy because you're spending time in simulation lab and you're doing your didactic courses. For me, I was really fortunate, and you never know how it's going to be until you start dental school, that my hand skills, so the simulation lab, was a little bit easier for me. The didactics took a little bit more time for me because I only did 3 years of undergrad. So some classes, like in, well, I did take anatomy, so like physiology, biochemistry, several of these classes, it was my first time taking these classes, so I had to spend more time studying, and I was fortunate that I could spend less time in simulation lab. Some of my classmates, my oldest classmate was 45 years old. It was a second career for them. Some of them had done a post-bac program. So several of my classmates who had already taken these classes, they didn't have to spend as much time studying. So they were able to spend more time in simulation lab practicing. So I think it's hard to say, but I think that maybe the biggest transition coming in is you have to figure out how to manage your time, because there's a lot that you're going to be learning. And so it's kind of just doing reflection and assessing what are your strengths and what are your weaknesses and what you have to do each quarter or semester, however your dental school works, so that you can manage your time well to work on the area where you're a little bit weaker. And then, I mean, obviously I still had to spend time in simulation lab to do all my practices and everything, but I think it's just being able to manage that time accordingly.
And then how would you say that the competitive nature of the school is? Would you describe it as competitive, or would you say more like collaborative, or just like the environment?
Yeah, in dental school?
Yeah.
Yeah, I think by the time you get to dental school, luckily it's pretty collaborative because you're working so hard to get to dental school, and it's really nice because you're all in the same boat. You've all never, I mean, unless you had a career as like a lab tech or something, most of you have never prepped a tooth before. You know, most of you have never numbed a patient before. So you're all kind of back at this level playing field. It's not like college, and you've already gotten the GPA, you've already taken the DAT. And so it's just an exciting place to be in dental school because everyone's helping each other. They're like, oh, here, I have the study guide for this. And, oh, I'll help you with this prep. I did this other prep already, so I can help you with this one. You know, there's just, everyone works together. And I mean, this was just my experience, but it's what I've heard from most of my friends. The really great thing now is dental schools are pretty much all humanistic now. So it's a really great environment. So I think it's something you should look forward to.
Yeah. Cool. And then kind of going more into your career now, what do you think is your most difficult case that you have had to work on?
Oh, that's hard. I think the most challenging thing I come across still, and according to my mentors, it does get easier with time, is when there's a treatment plan that I recommend for a patient, but the parent's not on board. That's probably one of the most challenging things I see. And we only have so many ways that we can treat cavities still. And it's really sad for me when I go over all of the possible options and a parent still doesn't want to do anything, because even if I go over your patient, like your child will start to experience pain if you leave this cavity, right? Here are all the risks of what can happen. So that's probably the most difficult thing that I come across is how to talk to the parent to show them that I am their child's advocate and I'm advocating for getting these cavities fixed and getting them back to a state of oral health to help set them up for that lifetime of oral health. And so our office is actually doing what we call fortune management coaching. So this is where they come in once a month to our practice, and they're going over different ways that we can improve our practice in general, not just dentistry specifically, but for example, how to talk to people, how to have a better team environment, just different things. And one of the things they've gone over with us is how to read different personality types. And it's really been helpful because some parents are very direct and they're like, okay, there's a cavity, what do I do to fix it? Let's get blood, right? Some of the parents, especially in Silicon Valley, are engineers and they want to know all of the materials you're going to be using. They have a lot more detailed questions. So if you go over all of that with them beforehand, they're like, okay, now I understand the process, sign me up, right? And some of the parents are just really social. And if you don't ask them how their weekend was, they're going to be like, oh, I don't really like what's going on here. And they're not going to want to schedule the treatment plan, right? So it's just figuring out, it's called the DISC profile, DISC, if you want to look that up. You can even take it for free yourself online. So just different things like that to figure out how you can better improve your practice going forward.
Okay, that makes a lot of sense. Well, in that case, that's going to be our last question of the session. Again, we want to thank you so much for joining us. This was an amazing presentation. And thank you everybody who is watching.